Dr. Fagan from the Academy of Online Radiology Education. I work at Baylor College of Medicine. This month we have curated some interesting literature in GI radiology. Our first article comes from Abdominal Radiology. A recently described parameter for assessing prognosis in rectal cancer is extramural venous invasion, or EMVI. EMVI is defined as the presence of tumor cells in the veins beyond the muscularis propria. MRI is useful in detecting EMVI at initial diagnosis and after treatment. This study assessed certain features including size, diameter, and large vein involvement, which the authors described as superior, middle, or inferior rectal vein, on MR detected extramural venous invasion and their impact on neoadjuvant therapy response in rectal adenocarcinoma. The authors studied 57 patients with advanced rectal adenocarcinomas who underwent MRI before and after neoadjuvant therapy. On pre-neoadjuvant therapy scans, 17 patients were MR-EMVI negative and 40 were MR-EMVI positive. The authors found that complete or near-complete responders had less number and smaller diameter of MR-EMVI when compared with partial responders. Large vein involvement was not statistically associated with treatment response. Additionally, MRI was found to have a high sensitivity for EMVI detection and a moderate specificity for EMVI detection. These findings show that the size and number of EMVI are clinically significant in determining prognosis for patients with rectal cancer and should be incorporated into MRI evaluation of these patients. Our next article also comes from Abdominal Radiology. Advances in the treatment of locally advanced rectal cancer has created more options for patients. Patients who respond well to neoadjuvant chemoradiotherapy may be offered a watch-and-wait approach rather than surgery. This approach can be limited by the poor accuracy of diagnosing clinical complete response. Digital rectal exam has a specificity of 56% and a sensitivity of 24%, and endoscopy has a sensitivity of 65 to 87% and a specificity of 39 to 78%. Rectal MRI can also have variability in its ability to diagnose clinical response as well as suffering from intra-observer variability. To address these shortcomings, ongoing studies are aiming to find radiomics features that develop more reliable methods for predicting complete response. The authors selected 13 studies which explored imaging features to predict complete response to determine which features showed high intra-reader reliability. In the model developed by the authors, intra-reader agreement varied from 0.73 to 0.93, and inter-reader agreement varied from 0.60 to 0.99, demonstrating that these models can show high levels of reliability. Our next article comes from the Journal of Gastrointestinal and Abdominal Radiology. Recent advances in the treatment of rectal cancers has allowed for a subset of patients to be treated with neoadjuvant chemoradiotherapy instead of primary surgery. Accurate local staging of rectal cancers is crucial in differentiating which patients can be appropriately offered each option. MRI has served as the standard for local staging of rectal cancer due to its superior distinction between bowel wall layers. Recent literature has suggested that advances in CT, such as CT perfusion, may allow CT staging to perform equally well. The authors therefore aim to evaluate the accuracy of high-resolution CT for local rectal cancer staging, including patients with low rectal cancer, as CT has previously been shown to be less accurate in this group. In the study, patients underwent high-resolution CT for staging of rectal cancer prior to primary surgery or neoadjuvant chemoradiotherapy followed by surgery. The authors found that in differentiating stages T2 and less than T2 from T3 and T4 rectal cancer, accuracy was overall 91%, sensitivity 87%, and specificity 94%. In the primary surgery group, accuracy, sensitivity, and specificity were 89%, 76%, and 94%. In the neoadjuvant chemoradiotherapy group, accuracy, sensitivity, and specificity were 97%, 100%, and 94%. In the low rectal group, accuracy, sensitivity, and specificity were 94%, 89%, and 97%. These results demonstrate that high-resolution CT is an accurate tool for staging rectal cancer. Our next article comes from Abdominal Radiology. Microsatellite instability is an important feature in gastric cancer and can help direct cancer treatment and change the options for treatment offered to a patient. Due to this, important testing of newly diagnosed gastric cancer for microsatellite instability is routinely performed. Currently, testing for MSI is performed via immunohistochemical staining or molecular biology tests requiring biopsy or surgical pathology samples. The authors of this study aim to construct and validate a radiomics feature model based on CT images and clinical characteristics of gastric cancer patients to predict MSI status prior to surgery. The preoperative CT scans of 189 gastric cancer patients were divided into a training and validation group. Radiomics features, including tumor morphology and features that describe the texture of the tumor interior and surface, were extracted from the images. The only clinical features found to be significantly correlated with MSI were tumor age and tumor site, and these features were included in the model. The authors found that their model predicted MSI status in the training dataset with an accuracy, sensitivity, and specificity of 0.72, 0.63, and 0.77 respectively, and in the validation dataset with an accuracy, sensitivity, and specificity of 0.67, 0.79, and 0.60 respectively. These findings demonstrate that radiomics markers in CT images can be used as a non-invasive tool for gastric cancer MSI status. Our last article comes from Abdominal Radiology. Acute appendicitis is generally diagnosed via CT in the emergency room. However, assessing for complications of appendicitis is an important adjunct to the diagnosis. Some recent studies have argued for antibiotic treatment of uncomplicated appendicitis, increasing the importance of detecting complications such as perforation and gangrene. The study aimed to investigate the preoperative features of appendicitis on non-contrast CTs and the time evolution of acute appendicitis and whether these factors could be used to predict gangrene and perforation of inflamed appendices. Imaging features analyzed included appendix diameter, appendicolith, appendiceal intraluminal gas, periappendiceal gas, and fat stranding or fluid, and short axis diameter of mesenteric lymph nodes. Time periods included pre-CT delay, preoperative delay, time between onset of symptoms and development of appendicitis complication, time between onset of symptoms and admission, and time between admission and surgery. With the exception of mesenteric lymph node diameter, all of the CT characteristics were found to be significantly different between simple, gangrenous, and perforated appendicitis. The presence of appendicolith was found to be an independent risk factor for both gangrene and perforation when analyzed using preoperative delay in a hazard model. The median time in these patients for gangrene was 104 hours if appendicolith was absent on CT versus 76.2 hours if appendicolith was present, and the median time for perforation was 103 hours if appendicolith was absent versus 77.5 hours if appendicolith was present. These findings demonstrate the interactions between timeline and radiologic features of acute appendicitis and can benefit the radiologist's ability to evaluate for complications. For more details, you can read our blog where you can find links to the original publications. Please feel free to share your thoughts and questions with us on the GI forum, and see you next month.